Thank you. Dr. Murata did a beautiful job of framing the significance in the clinical presentation of graft versus host disease. And as he explained, it's a hematopoietic stem cell transplant used for the treatment of many hematologic and non-malignant life-threatening conditions. And we're seeing increased number of these procedures, therefore we're seeing increased number of cases of ocular involvement. As Dr. Murata talked about, GVHD occurs when the transplanted bone marrow mounts an attack against the host. Acute systematic GVHD develops in approximately 40% of HLA-matched patients. Chronic GVHD develops in 30 to 70% of patients transplanted. As Dr. Murata said previously, acute versus chronic was defined as the time after transplant, but now we base acute versus chronic on the symptoms and the clinical findings. Ocular manifestation occur in 60 to 90% of patients with GVHD, and we'll talk about the different effect on the ocular surface, the cornea, the conjunctiva, the eyelid, and the lacrimal gland. And in many of these patients, it can have a very significant impact on their quality of life. Classic acute GVHD has skin involvement, GI involvement, liver involvement, and occurs typically within 100 days post-transplantation. Persistent or recurrent or late acute GVHD have the features of the classic acute findings without diagnostic or distinctive signs of chronic GVHD, and occurs 100 days post-transplant, and most often after discontinuation of systemic immunosuppression. There's various features, including the ocular features, that are diagnostic and then suggestive of GVHD, trying to make a clinical diagnosis. And as Dr. Murata talked about, there's an overlap syndrome that has features of both acute and chronic GVHD. But my charge today is to talk about the ocular findings in these conditions. And first we'll talk about acute graft versus host disease. And we think of it as a severe conjunctivitis. It can be a pseudomembranous conjunctivitis with conjunctival hyperemia, chemosis, and this pseudomembrane formation. Again, it's related to the interaction of the lymphocytes with the host histocompatibility antigens. Conjunctival involvement in acute GVHD is really a prognostic factor. If we see conj involvement, there's a higher rate of mortality occurring in patients with conj involvement than without conjunctival involvement. The classification based on clinical findings of the eye would be stage 1, conj hyperemia, stage 2, conjunctival hyperemia with a chemotactic response and an exudate. Stage 3 is pseudomembranous conjunctivitis, and stage 4 is pseudomembranous conjunctivitis with corneal epithelial sloughing, and this is a very severe form of acute GVHD with really serious complications for the cornea. The ocular findings in chronic GVHD are the most frequent that we see, and is one of the most frequent long-term complications for these patients, and really has significant morbidity and decreased quality of life. We typically get a severe chronic dry eye that affects the conjunctiva, the meibomian glands, the goblet cells, and then finally secondary involvement of the cornea. Again, the etiology is inflammatory-based T-cell mediated inflammation, and this is why we'll talk about the approach of anti-inflammatory medications to control ocular GVHD. The symptoms the patient will complain of are dry eye, frequent blinking and squinting, burning and foreign body sensation. These patients have severe photophobia, are quite uncomfortable, and then with corneal involvement of the dry eye will have significant loss of visual acuity. If we look at the ocular findings in chronic GVHD, we can see a pseudotosis, we can see findings of meibomian gland dysfunction, we can see lid and conj erythema and edema, telangiectasia, we can get cicatricial entropion, and then occlusion of the lacrimal system, the puncta, which often is actually helpful for these patients. The conjunctival findings, hyperemia, chemosis, exudative changes, the pseudomembranous conjunctivitis, and then finally in the chronic progressive inflammatory reaction, the cicatricial changes we'll now see, which really are the signs of a chronic severe dry eye with loss of goblet cells and lacrimal gland function. And this is a patient with a pseudomembranous conjunctivitis. And now we see stages of the subepithelial fibrosis, the loss of the fornices, and then Franks and blepharon formation in these patients with chronic GVHD. Patients who have corneal involvement are at great risk for corneal scarring and eventual perforation. They can present with a punctate keratopathy as the early signs of dry eye, and then secondary corneal epithelial sloughing. Classically, we see filamentary keratitis in patients with loss of goblet cell formation, and we can see superior limbic keratoconjunctivitis in some of these patients. The progression then leads to corneal ulceration, secondary neovascularization, scarring, and even perforation in the worst cases of dry eye. Here we see a large corneal erosion. Here we can see chronic scarring, thinning, and significant loss of vision. If we classify chronic conjunctivitis and GVHD, stage 1 is conjunctival hyperemia. Stage 2 is palpebral conjunctival fibrovascular changes without epithelial sloughing. Stage 3 is palpebral fibrovascular changes in less than 75% of the total surface area. And finally, stage 4, more than 75% of the surface area will be involved. As Dr. Moretta talked about, the National Institutes of Health has defined these chronic scoring systems in chronic graft versus host disease. Stage 1, dry eye symptoms really not affecting the daily life or quality of life, would be less than, eye drops less than 3 times per day, or asymptomatic signs of early dry eye. Stage 2 is dry eye symptoms partially affecting daily life. That means artificial tears more than 3 times a day without a change in visual acuity. And then finally, stage 3, dry eye symptoms significantly affecting the quality of life, patients requiring special eyewear to relieve dry eye pain, or unable to work because of pain or decreased visual acuity. So in conclusion, ocular involvement with graft versus host disease is a common long-term problem we see in bone marrow transplant patients. I think as clinicians, even if you are not primarily a corneal specialist, you'll be seeing these patients in your practice, and it's important because sometimes the ophthalmologist is the clinician who diagnoses chronic GVHD. This can lead to frequent morbidity and significant reduction in quality of life for these patients, and aggressive treatment of dry eye and interaction with the bone marrow transplant team is paramount to get success in these patients. Thank you.